Cardiac disorders in pediatrics. Now we'll be looking at outflow obstruction in the well child. These lesions are number 1, aortic stenosis, number 2, pulmonary stenosis, and number 3, adult type coarctation of the aorta. First, we'll be looking at aortic stenosis. Aortic stenosis. The aortic valve leaflets are partly fused together, giving a restrictive exit from the left ventricle. There may be 1 to 3 aortic leaflets. Aortic stenosis may not be an isolated lesion. It is often associated with mitral valve stenosis and coarctation of the aorta, and their presence should always be excluded. Clinical features of aortic stenosis. Most present with an asymptomatic murmur. Those with severe stenosis may present with reduced exercise tolerance, chest pain on exertion, or syncope. In the neonatal period, those with critical aortic stenosis and a duct-dependent systemic circulation may present with severe heart failure leading to shock. Physical signs of aortic stenosis include number 1, small volume, slow rising pulses. Number 2, carotid trills, which is always there. Number 3, ejection systolic murmur, maximal at the upper right sternal edge, radiating to the neck. Number 4, delayed and soft aortic second sound. Number 5, apical ejection click. Investigations of aortic stenosis include chest radiograph and ECG. For the chest radiograph, it will either be normal or you can see prominent left ventricle with post-stenotic dilatation of the ascending aorta. In the ECG, you can see there may be left ventricular hypertrophy. Management of aortic stenosis. In children, regular clinical and echocardiographic assessment is required in order to assess when to intervene. Children with symptoms on exercise or who have a high resting pressure gradient of more than 64 mmHg across the aortic valve will undergo balloon valvotomy. Balloon dilatation in older children is generally safe and uncomplicated, but in neonates this is much more difficult and dangerous. Most neonates and children with significant aortic valve stenosis requiring treatment in the first few years of life will eventually require aortic valve replacement. Early treatment is therefore palliative and directed towards delaying this for as long as possible. Now we're done with aortic stenosis, we'll be looking at pulmonary stenosis. The pulmonary valve leaflets are partly fused together, giving a restrictive exit from the right ventricle. Clinical features of pulmonary stenosis include most are asymptomatic. It is diagnosed clinically. A small number of neonates with critical pulmonary stenosis have a duct-dependent pulmonary circulation and present in the first few days of life with cyanosis. Physical signs. Number 1, an ejection systolic murmur best heard in the upper left sternal edge. The trill may be present. Number 2, an ejection click best heard in the upper left sternal edge. Number 3, when severe, there is a prominent right ventricular impulse, felt as a heave. Investigations of pulmonary stenosis. We'll be talking about chest radiograph and ECG. For the chest radiograph, it might be normal, or you might be able to see post-stenotic dilatation of the pulmonary artery. On the ECG shows evidence of right ventricular hypertrophy, which is shown as an upright T wave in V1. Management of pulmonary stenosis. Most children are asymptomatic, and when the pressure gradient across the pulmonary valve becomes markedly increased, about 64 mmHg, intervention will be required. Transcatheter balloon dilatation is the treatment of choice in most children. Now we're done with pulmonary stenosis. We'll be looking at adult type coarctation of the aorta. This is uncommon lesion. This uncommon lesion is not duct dependent. It gradually becomes more severe over many years. Clinical features of adult type coarctation of the aorta. Asymptomatic. Number 2, systemic hypertension in the right arm. Number 3, ejection systolic murmur at the upper sternal edge. Number 4, collaterals heard with continuous murmur at the back. Number 5, radiofemoral delay. This is due to blood bypassing the obstruction via collateral vessels in the chest wall, and hence the pulse in the legs is delayed. Investigations for adult type coarctation of the aorta. So we'll be talking about chest radiograph and ECG. For the chest radiograph, you might be able to see rib notching due to the development of large collateral intercostal arteries running under the ribs posteriorly to bypass the obstruction. And you might be able to see the number 3 sign with visible notch in the descending aorta at the site of coarctation. On ECG, you'll be able to see left ventricular hypertrophy. Management of adult type coarctation of the aorta. When the condition becomes severe, as assessed by echocardiography, a stent may be inserted at cardiac catheter. Sometimes surgical repair is required.